Hi guys, this lecture is head and face anatomy, and we are going to go through this just as the end of the semester introduction to head and face anatomy. There will be a quiz. It will be 10 multiple choice questions, and it will be based on the PowerPoints only, nothing from your textbooks or anything like that. I want to go through this with you all so you have an idea of what we're going to do in the spring. We are going to do this probably in Autumn's class. We'll go through all the special tests and the evaluations, but there's quite a bit of information, and so it's a good review, and it'll be good to get it into your minds before you even get started. So, head and face anatomy. You should probably remember this from Dr. Sabin's applied palpation anatomy class, but there's a lot of anatomy in this PowerPoint. So your clinical anatomy is your skull, so you always want to remember the different parts of the brain. So your frontal lobe, your parietal lobe, your occipital lobe, and your temporal lobe, and each of those have bones that correspond with those. It's important to remember that your skull protects your brain, and so when you think about an injury, a skull injury, it's not going to present the same way as just a regular long bone, right? You need to think about the fact that the skull is sutured together. The sutures are the joints that hold the bones together, and they don't really expand that much. And so when we're looking at injuries in the skull, you're going to think about like more of an indentation in the skull for a fracture, or blood coming out of the ears as a fracture. So you want to consider the shape of the bones, the density of the skull. The skull is actually pretty dense. And then you have to remember that there's skin that overlies it and hair, and that all protects the skull and the brain. So here's another picture of the skull, just for your basic anatomy to review. The bones are considered flat bones. They are immovable joints, and the most important part of the skull is that it protects your brain. And so if anything happens to your brain, it is within the skull, which means that it doesn't really have any place to expand, but the function of the skull itself is to protect the brain. This is just another anatomy picture. It's a lateral view of the face. You can see the zygomatic arch, your temporal mandibular joint, and where your ear goes, your external auditory meatus. You can also see on this picture the coronal suture, which joins the parietal bone and the frontal bone. Use this as a review. Again, this is if you took off the maxilla of the skull. It is where all of the foramens are. You can see where all of the cranial nerves come out. So any place there's a foramen or an ovale, you're going to have, that would be one of the places where the cranial nerve comes out. You can see where the carotid artery is, the mastoid process. You can see the palatine bone and the hard palate of the mouth. So this is just another view of the skull. Here it is again. I thought I'd provide you guys with lots of pictures, just as a good review. So here's your clinical anatomy of the brain. These are the primary parts of the brain I'd like you to know. The spinal cord, the cerebellum, and the occipital lobe is your brain stem. And why that is really important is because your cerebellum does function to maintain your balance and coordination. If you want to remember how that goes, I always think of cerebellum, B-E-L-L. You can get your bell rung. And then you can't have very good balance or coordination. So that's how I remember cerebellum, what it does. Your cerebrum is your primary motor functions, sensory information, special senses. So the cerebrum is the part of your brain that controls the left and the right, functions contralaterally. So the left side controls the right side of the body, and the right side of the brain controls the left side of the body. The primary motor cortex and the primary somatosensory cortex, those are the places where the movements in your body are really processed. So you perform a motion like reaching to pick up a cup. What happens is as you go to reach to pick up that cup, for example, you have to decide how fast you're going to do that, where you're going to put your hand. Are you going to go fast, slow? Does it have to go to the left or the right? Those spatial and temporal cues come from the primary motor cortex. So those are pretty important parts of the brain to understand. The temporal lobe tends to do with short-term memory. Frontal lobe is the part of the frontal lobe is your personality. So a long time ago when they used to do lobotomies, ever heard of a lobotomy? They take out the frontal lobe, and that changes people's personality completely. So that's kind of scary, but that's what they used to do back in the day. Now we just know that the frontal lobe does have a lot to do with your personality, and so a concussion where the front of the head is hit, or where the brain sloshes around and hits the front of the skull, can change someone's personality. And so when you think about people having concussions or issues with their brains, a personality change is quite common as one of the signs and symptoms. Other parts of your brain. You have a diencephalon, which processes this is just more specific, processes the input and output sent from your efferent and afferent nerves that go in and out of your brain. And your hypothalamus regulates parasympathetic and sympathetic nervous systems. So your fight or flight, or your just ability to have your everyday activities, okay? How you respond to things, your emotions and things like that. Like I already mentioned, your brainstem functions to relay information and controls in the involuntary sensory nervous system. Some other parts of the brain that are important to know about is your meninges. They are the first protection of your brain after the skull. So these are thin, porous parts of the brain, and they provide cushioning, and they buffer the brain and the spinal column. Damage to the meninges can be life-threatening. So I like to call them the brain pad. So starting closest to the brain, you have the pia mater that covers the brain. And then you have a space in between that contains a lot of blood vessels, and it sort of looks like a spider web, and for that reason it's been called the arachnoid matter. And then you have two layers getting closer to the surface where the skull is. You have two layers of dura mater. And the dura mater is an outer lining of the brain, and it lines the skull. What's important about the subarachnoid space as part of the arachnoid space is that it's filled with cerebral spinal fluid. So your brain sort of floats around in cerebral spinal fluid. And all of these work to protect the brain. So there's a lot of protection for the brain that the body naturally has, in addition to the football helmet that a football player wears. So any kind of damage to your dura mater or your subdura mater can potentially be life-threatening, okay? Bleeding in the brain. So if you had, like in picture A right here, where there's an epidural hematoma, if you have a fracture in the skull, it can cause bleeding of the epidural mater. All of this increases the pressure in the brain. Similarly, a subdural hematoma, same thing. This is bleeding between the arachnoid space and the pia mater. it puts pressure on the brain. And part of the issue with that is that the skull itself cannot expand. It is sutured together using the sutured joints, and it does not expand. And so if there is swelling in the brain, it does not have any place to go. And that is one of the reasons we are so concerned about damage to the brain. So here's another picture, what we do with a concussion, and we'll talk a lot more about this, and we talk about this in Gen Med, but we will talk a lot more about this as we get into the spring semester. But just for a review, when you send your athletes who get hit and you think they have a concussion, when you send them to the doctor and they get a CAT scan, what it is doing is ruling out a subdural hematoma or an epidural hematoma. If that happens, if they rule both of these out, then a concussion is ruled in. And we all know that a concussion can be equally as dangerous as bleeds on the brain, okay? So a negative CT indicates a concussion, and a positive CT indicates bleeding in the brain. Now, with bleeding in the brain, they will keep someone in the hospital. Depending on the amount of swelling in the brain, they may remove the skull so that the brain has some space to swell and then go back down. That's all very, very serious injuries that need to go to the hospital. So your epidural is between your skull and your dura. Again, usually these mechanisms of injury are associated with a skull fracture or trauma to the skull. And then a subdural bleed is between the dura and the arachnoid matter of the brain. And again, that can also be a blow to the head. An epidural bleed usually has signs and symptoms that come on pretty quickly, whereas a subdural bleed will come on slowly. So it could be close to a week that the patient slowly deteriorates and they have headaches and they can't sleep well. They experience nausea, they have ringing in their ears or blurriness in their eyes or sleepiness. They just complain overall they do not feel well. So those are some of the reasons that you really need to monitor concussion patients following a head injury. So we just talked about bleeds in the brain, and why do we have so many bleeds in the brain? Well, let's take a look at this picture. This guy has got some serious blood vessels in his brain, right? So your cerebral spinal fluid buffers and controls blood flow in the brain. And as you notice, there's a lot of blood flow. So at rest, 20% of your oxygen goes to your brain, and it will go through your common carotid artery, which is anterior. You can feel it under your neck, there in the anterior portion of your neck, through your vertebral arteries, which come up through your vertebrae. And so when we take a look at the vertebrae, we're going to see that there's little triangular foramen in the cervical vertebrae, and that is for your vertebral arteries. They supply the blood in your brain. And then we have what's called the circle of Wills, which is essentially an anastomosis, which allows blood to go in each direction. So it can flow in one direction, and if there's damage to the blood supply in one direction, the blood can actually turn around and flow in the other direction. So it gives it a little bit of a detour route in the event that there's damage to the brain. Okay, so going into your vertebrae. So here is our anatomical review. You guys already talked about the thoracic and lumbar vertebrae with Dr. Sabin. And one of the things to remember is that form follows function. And what I mean by form following function is that the size and the motion of the parts of the body basically have adapted to the different types of functions that we do in everyday life, right? So you think about the shoulder, and it has a really narrow little socket. The glenoid's really small, and the humerus is really big so that you can reach over your head, and that's the body has adapted that way over years. The cervical spine, the cervical vertebral column, the 7 vertebrae, are very small and they're very mobile because you need to be able to move your head all around to do things, right? Could you imagine if you had a big, thick vertebrae in your neck and you tried to turn your head left to see if something was coming, like a car when you were driving in your car? That would make life really difficult. So instead, we have teeny tiny little vertebrae in our cervical column, and that allows us to move our head around and move in all different directions. Little animation there. So your spinal column has your 7 vertebrae that make up your vertebral column, and the size and shape are based on function, which I already stated. So the motion segment is the functional unit of the spine. So if you look in this picture over here, you can see that there's a spinous process, there's a vertebral body, which is similar, a transverse foramen, an anterior tubercle of the transverse process. You can see where the spinal nerves come out and where there's gray matter and white matter, and the dorsal and ventral root, which control the sensory and motor nerves respectively. Okay, so take a look at this picture. There's a lot going on in the spine, and we will go more into it in the spring, but I just want you to be able to see this. So here's some more cervical spine pictures. Okay, you can see there's a transverse foramen, a vertebral foramen. Here is your atlas, which is your C1, and your axis, which is C2. So what makes these two particular vertebrae important is, 1, they have vertebral foramen, and 2, they have the dens and the atlas. And essentially, if you look on the atlas on C1 and you can see those little pedicles right there, the skull actually sits right there. So in order to find C1, you actually, on yourself, you actually have to palpate behind your ears, find your mastoid process, and just go just distal to that, and that's where you're going to find your C-spine. So your C1 and C2, your whole head rests on that. Your anatomical parts, you have your body, your vertebral arch, articular process, your pedicle, and your intervertebral discs, probably very important. Spinous processes and transverse processes of your spinous processes. They have attachment sites for muscles and ligaments, and you also have your nerves that come out through between your intervertebral discs. So this is anatomy that is worth reviewing. Here's a good picture. See the differences between the 4th cervical vertebrae and the 7th. As you notice, the 4th is a lot smaller than the 7th, and that is because the 7th vertebrae, also known as your vertebral prominence, because it has a very long spinous process. As you get down to C7, your cervical vertebrae becomes more of a support type vertebrae than motion, and so there's differences in the spinous process. We have covered this, except the very important triangular shaped vertebral foramen, which allow the blood supply to get to the head. So that's where your vertebral arteries come through. Again, C1 and C2, the atlas and the axis. Just about everything I've already said, except big piece of information you might want to put in your notes, that if the dens of the axis gets injured, you can be paralyzed, and that could cause death. Also, there is no disc between C1 and C2. They sit right on top of each other. Different types of C-spine injuries. The cervical spine is very vulnerable. The motions that it makes is flexion extension. You have your lateral tilting to the left and the right, and then you have rotation. Okay. The different types, probably the most common injury you would have is flexion and axial compression of the cervical spine, which is what this picture shows. By the time you get to the flexibility or the flexion of the cervical spine, you can see where the disc is sticking out. That damages the disc, it damages the anterior longitudinal ligament, and it damages the nerves coming out of the disc themselves. This is the mechanism of injury that goes with spearing. This is exactly what happens to your C-spine in a spearing, or now called helmet-to-helmet contact, in college football that has become very a lot more commonly looked at these days. So there was a point in time in the 70s where there's a spearing rule that came about in the NFL in 1978 that tried to prevent football players from crashing into each other with their heads to prevent paralysis, and there was a lot of injuries. That injury sort of fell by the injury didn't fall by the wayside, but the mechanism of injury and the NFL actually really paying attention to the damage of that sort of fell by the wayside in the 80s, and more recently in college football and in the NFL, there's been a resurgence of, gosh, it's really not good to ram my head into another player because I can get paralyzed. So now there's all kinds of penalties for it, and that's a good thing because we like to protect our players. And that's why we're always talking about proper tackling technique. Another injury that you can get is a cervical sprain or strain, which is obviously injury to the ligaments or the muscles of the cervical spine. This is a good picture of normal ligaments versus an injured joint capsule. The mechanism of injury is just what you would think. Extreme range of motion. You get rear-ended by a car, motor vehicle accident. If anyone watched the Northwestern Ohio State game on Saturday night, you could see that the quarterback for Northwestern got hit so hard a couple times. He had some whiplash. The hits were legal, but they hit him so hard from behind, you could just see his neck just violently flex and extend. He seemed to be okay, though, finished the game. So the signs and symptoms of a cervical spine injury would be pain and stiffness, decreased range of motion, and it would last longer than 5 days. So if you have an athlete complaining of these types of symptoms, probably in addition to ice and probably some massage, see how they feel, it would be really important to send them to the doctor to just follow up. You can also fracture your spine. You can fracture your spine. You can dislocate your spine. This is actually a real MRI of a friend of mine who fractured her first and second cervical vertebrae and her fourth cervical vertebrae while mountain biking. She hit the front brake and went right over the handlebars and landed square on the top of her head. She's fine today. She's up and moving, but as you can see, a fracture in the facet of C1 probably is not a very good thing. You can actually, if you look closely, you can see on the right picture where the fracture is, because there's a little circle with red under it, and you can see the dens sticking up from C2. So she was pretty lucky. Signs and symptoms of this are the same kinds as you would think with any kind of fracture. Radiating pain because there could be damage to the nerves, numbness and tingling, pain to touch directly over the spine, weakness, and you could always worry about a loss of bladder control. My friend didn't have a loss of bladder control, but any type of damage to the nerves themselves is going to cause a chain reaction, so a loss of bladder control can occur. What do you do if your patient has this, or your athlete if you're down on the field? Call 911, stabilize the neck. You all know how to do spine boarding. Dr. Fuchs taught you that. You always want to treat for shock, so you need a blanket or a coat or something like that, and then monitor your patient's vital signs and get them to the hospital as soon as possible. Concussions are the next set of serious head injuries that we're going to talk about. I have attached a third email that has, or not email, excuse me, I've just attached a third PowerPoint lecture, that is Dr. Sabin's concussion PowerPoint. He was gracious enough to share this with us. This is his research. He is the pro with this. He knows the stuff, but I would like you to take a look at these slides. We will highlight the important information and follow up and discuss all of this in the springtime. That's just to give you an idea of what's going on. Okay, future plans. We are going to review the pathologies. You're going to learn how to do a full evaluation of the head and neck and the face. And I'd like to thank you for your continued patience. Thanks so much. I hope you enjoyed having a lecture that you could watch at any time of the day.